This lecture will entail distinguishing and learning the difference between manual muscle testing and muscle selective tension testing. Both of these are foundations for evaluation, differential diagnosis, and prognosis. The learning objectives for today with this presentation: students will know the meaning and purpose of manual muscle testing and muscle selective tension testing, and how they apply to the foundations for evaluation, differential diagnosis, and prognosis. Students will be able to apply and demonstrate manual muscle testing and muscle selective tension testing, test and measures, and interpret and verbalize and document the findings accurately. Manual muscle testing and muscle selective tension testing, definitions and purposes. So what is the definition of manual muscle testing? It is a test performed via the application of external manual resistance. Therefore, we test the muscles with using our hands. That's what manual means, the use of our hands, and applying an external force with the use of our hands. The purpose of manual muscle testing is to determine whether a specific muscle or muscle group is sufficiently active or strong. Okay? Again, manual muscle testing is to determine whether a specific muscle or muscle group is sufficiently active/strong, or whether it's weak versus strong. Muscle selective tension testing is a test performed via the application of external manual resistance. So with both manual muscle testing and muscle selective tension testing, both consist of testing the muscle via external application of manual resistance. However, what differs with muscle selective tension testing is that it is to discern muscle pathology and or condition. So what do we mean? To discern whether the muscle attending is tendinosis, tendinitis, partial tear, or complete tear. All right? So what is the difference between tendinosis and tendinitis? When we talk about tendinitis, we're talking about an acute inflammatory condition of the tendon. So acute being typically 1 to 7 days when we're talking about acute. And tendinosis is chronic in nature. So tendinosis, you still have micro tears or either macro tearing of the tendon. However, this is a chronic condition that has been ongoing. Typically, we consider chronic about 3 months. CDC describes chronic as ongoing for at least up to a year. So that's the difference between tendinosis and tendinitis, is the time frame as well. And when we talk about a partial tear, we're talking about a tendon that is partially torn, anywhere from 25 to 50% torn. And then when we talk about complete tear, 100% of the tendon is torn. All right. So overall, when we compare and contrast manual muscle testing and muscle selective tension testing, if we compare both of them utilize the application of external manual resistance. However, when we contrast them, one is to determine whether the muscle or muscle group is weak or strong, and muscle selective tension testing, when we contrast it to manual muscle testing, it is to discern whether that muscle is in a healthy state, or whether that muscle, what the condition of the muscle is in. All right. Now, how do we grade manual muscle testing and how do we grade muscle selective tension testing? So both are going to come with some type of clinical impression or interpretation. So when we talk about manual muscle testing, in our Daniels and Worthingham's textbook with manual muscle testing, the grades are considered from 0 to 5. Okay, so with grade 5, that indicates that the person has a normal manual muscle testing score. The person completes full range of motion against gravity with max assistance. With the grade 4, we know that the grade is considered good and the person or patient completes full range of motion against gravity with moderate resistance. A grade 3 is a grade of fair, where the individual or patient completes full range of motion against gravity without resistance. So when you take a patient through gross range of motion and they're able to achieve the full range of motion against gravity without resistance, that automatically puts them at a grade 3. So when we're taking our patients through range of motion, we can quickly screen if this patient is at a grade 3 or not, by just if they're able to achieve full range of motion against gravity. With a grade 2, which is poor, the person's able to complete full range of motion in a gravity eliminated position. So for example, if the patient is sidelined and you want to assess the iliopsoas for a grade of 2, you have the person to perform hip flexion in a sideline position. And if they're able to achieve hip flexion in a sideline position with gravity eliminated, then that would at least be a grade of 2. All right. Same thing for shoulder flexion in a sideline position. Grade 1 would be a trace of muscle activity where the muscle contraction can be palpated, but however, no joint movement occurs. And then grade 0, no palpable muscle contraction. Now, when we talk about manual muscle testing, there are other grades. There are pluses and minuses, but those are not in Daniels and Worthingham's. So in Score Builders, in the Score Builders app, in the Score Builders test prep book, they have those plus and minuses. So I encourage you all to purchase the Score Builders app so that you can also study and know the pluses and minus descriptors as well, okay? So make sure you acquaint yourself and know those as well. So I'm gonna task you all with independently studying those and reviewing those. Yes.
Do you use the
Yes,
plus and minus in your clinic? I know it varies per clinic.
It does vary per clinic, but I do use plus and minuses in my clinic. So if you ever do a clinical internship with me, like I have students doing clinical internships during the summertime. So, and I do use the plus and minus as well. All right. So with muscle selected tension testing, this is what you all are gonna be required to do for your lab practicals. You're gonna be required to do and perform muscle selected tension testing. I'm gonna give your partner a scenario to act out. You're gonna have to interpret that scenario with muscle selected tension testing. So remember that I informed you all that muscle selected tension testing is gonna build upon manual muscle testing. So you have to have manual muscle testing commanded in order to move on to being able to perform muscle selected tension testing. So with muscle selected tension testing, it's gonna give you information to help you with differential diagnosis as well, and actually to maybe pinpoint specific muscles and tendons that could likely be involved. So if a person is able to, or a patient is able to hold resistance, meaning the muscle is strong and it is painless, without pain. So when you muscle selected tension test a muscle and that muscle is strong, that means that the person is able to hold your max resistance without pain. That is typically a healthy muscle without dysfunction. All right. Now, if a person is strong and able to hold resistance, but it is painful, that is typically a minor muscle or tendon dysfunction, something like tendinosis or tendinitis. Okay. Now, if your patient is weak, unable to hold resistance, and it is painless, that is indicative of a complete rupture or some type of nervous system dysfunction. If the patient is weak and unable to hold resistance, and it is painful, that is a serious muscle or tendon dysfunction, maybe a fracture or either a partial tear. Now, this is significant content because this content allows you to be specific with some type of involvement. So what do I mean by that, Dr. Carter? What do you mean by how does this muscle selective tension testing allow you to be more specific in your clinical impression. So I gave you an example in one class period, right? Where we talked about the drop arm test, all right? So Jackson, what did we say about the drop arm test?
That it wasn't indicative of any particular rotator cuff pathology. It was just indicative of rotator cuff pathology.
Okay, so Jackson pointed out. So come up, Jackson. So now Jackson pointed out that if I get him here and I bring him right here and I say, lower your arm to your side and try to lower your arm to your side. Go ahead, lower your arm to your side. So now he's able to lower his arm to his side. But say that so now lower your arm to your side and just say you have pain and pinpoint somewhere.
I have pain right here.
So he has pain right there. But we don't know, according to Conan, we don't know which rotator cuff could be involved. So it just says a positive drop arm test could indicate rotator cuff involvement. So now he has pain with the drop arm test, or he's not able to control it. So I'm gonna come right here and just drop him. All right, so either or, all right? So he's positive. So now, how do I distinguish? I know that Conan says it's rotator cuff involvement, but now, how can I distinguish which rotator cuff it is? I can perform muscle selective tension testing. So I can get him here, come right here. All right, I would like for you to hold this position for me. Hold this position and do not allow me to move you. So now my force is trying to move his shoulder joint, his glenohumeral joint into external rotation. So he is strong and say he had no pain. So if he's strong and had no pain with that, which muscle would I consider a healthy muscle and then I would move on? Subscap. So I would say the subscapularis is healthy. I don't think there's any problems with subscapularis. I'm gonna move on to muscle selective tension test, the next rotator cuff muscle. I'm gonna come right here. So, all right, I'm gonna come right here so that the camera can see me. And I'm gonna say, hold this position, don't let me move you. Hold, he's weak, all right? So good acting. Good job. So now he's weak. Now I have to know if it's painless or if it's painful. What would you say?
It was painful.
So he said it was a painful. So now that it's painful, what am I thinking? I'm thinking some type of serious pathology. It's weak and painful. So maybe a partial tear of which muscle? Likely infraspinatus. Okay, all right. That's a big rotator cuff muscle, one of the rotator cuff muscle that's going to play a major role in performing external rotation. All right. So now I'm going to get him and I'm going to bring him to about right here. All right. I'm going to say hold this position. Hold. So now he's strong. Any pain? So, all right, I take him to abduction, and I can test abduction at different ranges, right? I can test it at different ranges. But he's strong and no pain, so I'm saying, okay, likely he has a strong supraspinatus muscle, okay? All right, now, what's the other rotator cuff muscle?
Teres minor.
Huh?
Teres minor.
Teres minor. So I've already tested teres minor along with what? Along with infraspinatus, because both of those are going to do external rotation. All right. So now I have a clinical impression that he has involvement of the infraspinatus muscle. So now taking the drop arm test, which tells me that he has involvement of rotator cuff muscle, but we don't know which rotator cuff muscle. Now we can transition to muscle selective tension testing and utilize that to give us more information. All right. Now I'm going to give you all examples so that you know how to utilize muscle selective tension testing. We now are not. I know in Alabama, we just got direct access, but in many of our states, we have direct access. So now we need to be skillful, very, very skillful and knowledgeable when it comes to our foundations for examination, differential diagnosis, and prognosis. All right? Now, thank you, sir.
Thank you.
Good job.
Thank you.
Jessica just came to my clinic, right? Jessica said, oh man, I think I strained my hamstring muscle group. I was playing soccer. I think I strained my hamstring muscle. Then I want to go, okay. We want to see which muscle did she likely strain. Can we do that? You say we can, Ebony? What would you do? Say again?
MSTT.
Yeah, so you can do muscle selective tension testing. So how would you assess her different hamstring muscles? How would you isolate them?
Put her in prone.
Okay.
Test for medial and lateral.
Okay, like prone right here. Okay, come on up.
What is that?
I like that t-shirt. Oh yes, I love that.
Alright, so to test the hamstrings, you'll want to have our patient bend the knee.
Mm-hmm.
You know, the bicep is more on the lateral side, so
The bicep wet.
bicep femoris.
There we go, okay.
Bicep femoris on the lateral side, so we want to kind of turn her leg out. And we're going to say, well, first,
So
we're
you
going to
turn,
ask her to do it first. Can you
Okay.
bend your knee for me? Alright, good. Then we're going to ask her to come down to a neutral position, like right there. Alright, can you turn your toe out for me? Good. Alright, I'm gonna push you down. Don't let me push you down, okay? 1, 2, 3. And good. I would say she got 5
okay. So now,
for the bicep femoris isolation.
okay, so if you're muscle selective tension testing, so manual muscle testing, you're grading her 4, right? So with manual muscle testing, you're saying that she's able to complete full range of motion against gravity with moderate resistance. But what I want to know is your clinical impression for the muscle selective tension testing. See, this is what students trip up during the lab practical. You are tasked with providing your interpretation for muscle selective tension testing. And what do many of the students do, Dr. McClure? They give us an interpretation for manual muscle testing. And so then if you bomb that section, we don't say anything. If you bomb that section, and then you likely, that's a lot of points, and you likely put yourself at risk for having to do a retake. So that's why I'm taking time to go through this now. I'm taking time to explain this now, because we have to be well versed in this as physical therapists and then direct access practitioners, all right? So go back, take her through that motion. So let's put a real life example in here. All right, she goes back. This time you're gonna take her into the motion. You're gonna take her into flexion. You're gonna move her into flexion. All right, and you're gonna go through your command. You do a muscle selective tension testing.
Alright. Okay. So, stay lit. I'm gonna push you down, but don't let me push you down, okay? 1, 2, 3. Okay, did you have any pain while doing that?
No.
So I would consider her unable to hold resist. No, they ain't no good. Oh yeah, unable to hold resistant and painless. So she probably has a complete rupture.
Okay, all right. So if she's unable to hold resistance and it is painless, it could be a likely complete rupture of what? Because you isolated the muscle.
On the bicep femoris, so she probably ruptured her bicep femoris.
So there you go. So you isolated the bicep femoris according to Daniels and Worthingham's manual muscle testing book. Okay.
Emphasis on the possible. We don't say straight up, right?
There you go. Yes, we always provide a clinical impression because we don't say that it's 100% this. or we don't say this is exactly what it is. We always say, this is the information we got from our testing manager, this is my clinical impression, okay? All right, good. So now, you can isolate, there you go. So you can isolate semi-tendinosis and semi-membranosis by having the tibia go into where?
We're gonna turn her foot inward instead of outward.
There you go, internal rotation. So you internally rotating the tibia, and now when you perform the test, let's go through it.
I'm gonna push you down, push you down, okay? 1, 2, 3. Do you have any pain? So she has a healthy, semitendinosis and semimembranosis because she didn't break resistance and it was painless.
Good job. So I'm taking time to go over this because you're gonna have to do this on your lab practical. So your partner, Dr. McLaurin out, we're gonna give your partner a scenario to act out. And we depend on the partner to act it out. And you're gonna have to provide your interpretation for whatever your partner presents with when you perform muscle selective tension testing, all right? And we're gonna actually give you the muscle, so we're gonna tell you which muscle to perform muscle selective tension testing on. This is gonna go way back to having a command of manual muscle testing and knowing your muscle action, knowing what position to put your patient in, go through and pay fine attention to that. So for example, I'm gonna give you another example while she's down here. According to Daniels and Worthingham, the latest edition, I think I have the 10th edition. This is another one that can trip students up, where you can get points taken off. But Daniels and Worthingham textbook goes in and clarifies this. So now, if I wanna isolate, because you may get this, if you wanna isolate the posterior deltoid, what is the best position according to Daniels and Worthingham to isolate the posterior deltoid? So you can have the patient prone, and what position are you gonna take the GH joint into?
Abduction.
What do you say, Occasion?
Abduction.
Abduction. So you're gonna come right here, according to Daniels, scoot to the edge for me. Now, according to Daniels Worthingham, you have a person right here. I'll move you half the way. Hold this position and don't let me move you. Hold it. So she's weak. So say she's weak. You having pain with that?
Yes.
She's weak and painful. That isolated the posterior deltoid, and being weak and painful, that indicates a serious muscle or tendon dysfunction of her posterior deltoid. Is this making sense? All right. Now, according to Daniels and Worthingham, if I have the person right here, I bring her right here, and I have her to hold this position. Don't let me move you. Is the posterior deltoid isolated according to Daniels and Worthingham?
No.
No. What other muscle groups can be tested? So latissimus dorsi, major one, is doing shoulder extension, which is why if a person is limited with shoulder flexion, we have to assess the latissimus dorsi for extensibility, which is often neglected. We often do not assess the latissimus dorsi for extensibility. All right. So here are your references.
So a question about.
Yes, sir, Mason. Mason has a question.
A question about the like muscle selective tension testing. So while you're performing the motion, would you ask them while you're doing it if they have pain during that movement, or would you ask after? Like Ebony asked, like after, did you have pain with that movement? But like when you were doing Jackson's, you asked him while you were performing.
Well, one of the things that differentiate us as physical therapists is that we are constantly assessing. So with everything we do, whether we having the patient doing therapeutic exercises, neuromuscular reeducation, whether we having the patient do gait training, we are assessing before, during, and after. So if I'm assessing for pain, I'm assessing for it during and after. as well. Does that answer your question?
Yes, sir.
So I wanna know if it's painful or painless throughout the process.
Yes, sir.
Alright, good question. Any more questions? So these are the references. So notice, I asked you to, somebody pointed out earlier that, one of the PowerPoints showed that the person had 145 degrees of knee active range of motion was a normal range of motion. So in your presentation, you should have references. All right, I typically reference an AMA, okay? So at the end of my presentation, you will see where the content is coming from, okay? Okay, there we go. What questions do you have? Yes, Acacia?
So just to make sure I understand, a muscle selective tension test is the same action as the manual muscle test for that muscle. The only difference is when we give like our impression, it's not, oh, this patient has a 5 out of 5. It will be strong and painless or weak and painful.
Excellent job, Acacia, that is it.
Okay.
That's the difference. So the difference between, so ask your question again, Acacia.
The difference between a manual muscle test and a muscle selective tension test only the outcome of the test,
So-
instead of whole different test.
Yes, so that's the major difference. So it's the same, you're doing the same type of, you setting the person up the same, okay, as you would with Daniels and Worthingham's manual muscle testing test book. So it's the same setup, pretty much the same command. The only difference, the major difference is the clinical impression and the grading. So the grading, clinical impression tied together, okay? So for muscle selective tension testing, your impression is not gonna be this person is a 4 out of 5. That's manual muscle testing, okay? For muscle selective tension testing, your clinical impression is gonna be the potential or status of a condition that the person would likely have, okay? Muscle dysfunction. So looking for muscle tendon dysfunction pathology.
You still ask them to go through the range of motion before you start the test?
Now, you can actually go through the range of motion, you use your clinical judgment. So sometimes I would ask the person to go through the range of motion, or sometimes I would just put them in the range of motion. So if I think they can't get there, I will place them in that position and see if they can hold it and move from there. But you have to apply your clinical judgment. So some things are not straightforward cookie cutter. So that's why we get our license as well, to apply our clinical judgment. So some things you have to apply clinical judgment to. So if I'm already suspecting that they may have a partial tear or a complete rupture, I may passively put them in that position first, and just to see if they can even hold that position. You see?
Be overthinking it, and I may not be thinking it right, but you know how on the manual muscle test, a patient probably has, like, you just palpate for contractions, or they're at 0. Would we consider doing the muscle selective test if a patient is at 0, even though they know they can't do nothing, to see which muscle is aggravated, or we probably just wouldn't do it at all for a patient that probably like contracture or something?
Okay, this is a case again where you have to use your clinical judgment. So for me, if the person's at a 0, right, then there's no joint movement occurring. I'm gonna take that information and then I'm gonna utilize that for the next phase of my examination, okay? So it may be that this person's most likely not gonna be able to tolerate resistance. But now I may do it because then I may wanna know, when I do the resistance, I may wanna know the categories of painful or painless to add more information to my clinical impression. Does that make sense?
Yes.
Because now if I add those if I apply resistance and I wanna know if it's painful or painless, then I get a better impression, or I'm not even gonna say better, I may get a stronger clinical impression of whether it's a serious pathology, such as partial tear, or whether it's a complete tear. Cause if it's painless, then I may, okay, then this person hasn't had imaging, this person may need some MRI, because I'm thinking this person has a complete tear, you know. So good question. Any more questions? All right, so this concludes the lecture and presentation on the comparison and contrast of manual muscle testing and muscle selective tension testing.